Okay. Hello, I'm Dr. Josef Witt-Doerring. I'm here on behalf of the Alliance for Benzodiazepine Best Practices. And today we're going to be interviewing Alexis Ritvo, who's the medical director for one of I think it's kind of the largest organization out there at the moment, who's really promoting the safe prescribing of benzodiazepines. And we're going to talk about some of the projects and I guess some of the work that's been going on in this space, because a lot of people who may be listening to this, they may have had really bad experiences with benzodiazepines. They've been harmed. They're wondering, how does stuff like this happen, and what are people doing about it? So this conversation is really about what are kind of organizations doing about this, and I'm so pleased to have Alexis here. So Alexis, I'm going to turn it over to you, and I'd just like you to go ahead and introduce yourself.
Sure. Well, thank you so much for having me. So, as you said, I'm the medical director for the Alliance and have been for the past year. Took over from one of the founding members, Dr. Stephen Wright, and had actually met him through our work together in Colorado with the Colorado Consortium for Prescription Drug Abuse and their Benzodiazepine Action Work Group that we co-founded. And there's been a lot of great work being done between the Alliance and the Benzodiazepine Action Work Group and some of our other organizations, like the Benzodiazepine Information Coalition. I think all of these groups have some very similar goals and take kind of different perspectives. So the Alliance has really been focused on how do we decrease the overall initial prescribing of benzodiazepines, as well as how do we help make sure that those that are put on benzodiazepines are prescribe them more within the bounds of what we know is safe use of them or safer use, and that individuals that are started on them really understand what the risks are of these medications, especially if they end up on them longer term. So some of our projects have really related to that. I think with those organizations I mentioned, worked on a prescribing guidance as well as a de-prescribing guidance. And I say guidance instead of guideline because these were not, rigorous trials that were yet done. Certainly we need those. But these were rather kind of a review of the literature and evidence that is out there, and pulling it together to say, here's kind of what the evidence says and the recommendations of how you can more safely prescribe these, what you should make sure your patients know about. And there are links to those both on the Alliance website. They're, brief 2-page documents that we hope that both prescribers will utilize, as well as that patients would potentially take to their prescriber if they felt like they had not been well informed or wanted to make sure their prescriber was aware of these things. And it's similar on the tapering or de-prescribing side. It's a 2-page document that kind of gives an overview of the many different ways people might approach tapering, and especially warning folks that going too quickly until you know how someone might respond. We've seen a lot of people do poorly or become pretty destabilized. I guess another related project that we've done is some of the research or review papers that a group of us have been working on in the Alliance. One was trying to come up with the term for what we were going to call this protracted withdrawal state that a lot of individuals who were on prescribed benzodiazepines seem to develop, because it doesn't seem to quite fit, calling it protracted withdrawal or post-acute withdrawal, which are used a lot in the field of addiction. I should mention I'm an addiction psychiatrist by training. But what we're dealing with prescription benzodiazepines is most people taking them as prescribed and developing physical dependence and then having difficulty coming off. So a group of us kind of went through a process of, and I believe you were included in this group of email, of voting on different terms to try to come up with terms that we thought more accurately represented this protracted withdrawal state, and landed on the benzodiazepine-induced neurological dysfunction, or BIND, to try to kind of capture the fact that we're seeing people injured by benzodiazepines and that it has this multi-systemic but especially very focused on kind of brain and nerves impact on people. And so now trying to get some papers published that help explain both how we came up with this term, as well as some of the survey results we've seen of individuals suffering from bind.
And I think I'll pick up there because I think it's so needed because yes, it's common. Like so the constellation of these neurological and psychiatric problems which occur in a rare few people who are exposed to benzos. Sometimes it happens when they're on it. Sometimes it happens when they're withdrawn too quickly. It doesn't really quite fit the withdrawal term because when you go and you talk to a physician and you say, oh, I have this protracted withdrawal, it's almost like they assume that you're going to have this linear recovery where each month is going to be better than the next. And
right.
And they also think that, okay, maybe this is something that could go on for a handful of months and that's about it. And that doesn't really fit the clinical course of, I guess, what people are suffering from. So I don't know if you wanted to kind of expand on that, but that seems to be the main kind of concept for me, like finding something that really kind of captures it correctly. Yeah.
Right. The parallel I'm increasingly drawn to make for people is what we're seeing with long COVID. So you have this, granted, we're talking about something that we think that is induced by a prescription medication versus something induced by a virus, but this syndrome that is multi-systemic, multi-symptomatic. I think with long COVID, people are more apt to truly believe it's there because we have so many people affected all at once. And I think for those that have been injured by benzodiazepines, many of them have struggled to get, especially the medical community, to believe them, that it's caused from the benzodiazepines, depending on what their symptoms are or if they're coming and going a lot. I know they refer to it often as windows and waves of their symptoms. And so I'm hoping that as we see, more research and traction with things like long COVID, we can kind of emulate some of their successes to get more traction with educating the public and the medical community about bind and trying to understand it better and figure out how to better treat it as well as prevent it. I mean, I'd love to have a better idea of how to predict who's at greater risk for this as well, because I'm sure as you've seen, some patients do just okay, like with being on a benzo and tapering off, and others really suffer and are super sensitive to even the these micro tapers.
Sure. Yeah, no, that is totally correct. And yeah, I guess, I mean, one of the things that at least I noticed that people kind of struggle with is that, you could take a CNS medication, a psychiatric drug, and you could develop enduring side effects, from some kind of, I guess, presumed underlying damage and correlation. I mean, other things that I think of is, tardive dyskinesia on the antipsychotics, some of the sexual dysfunction with the SSRIs, which may endure for months after people stop, and sometimes years, which are now coming out. So I kind of consider this just like another piece of this kind of growing evidence that, hey, we should kind of be more aware of the consequences of long-term use of these medications. And I just think it's, just a great effort to try and find the name that actually kind of really fits and makes sense. Because like you said, when you have waves and windows, if you go in and, you're feeling great one time and you say, oh, I think this is past, and then a month later you have a big wave of these neurological symptoms, traditionally the physicians are going to say, okay, well, this is not related to that because what's this kind of strange clinical course when it comes and goes? That's not any kind of withdrawal I've ever heard of.
Yeah.
Yeah,
and more similar to what we might call relapsing remitting in something like, multiple sclerosis. So I think some of those models are there in other neurological diseases and psychiatric. And I think we just have to do a better job of believing our patients and listening to them and realizing that everyone's so unique, that these medications and everything else going on in their unique body is going to have its own unique presentation.
That's interesting that you said, we really have to listen to the patients and believe, because I feel like a lot of people have had experiences where, they've gone to academic centers or they've talked to doctors and maybe they haven't really been kind of believed about these problems. So I guess I wanted to ask you kind of what was your journey to this space and to kind of, recognizing that protracted withdrawal was a thing. How did you stumble here and then become interested enough to become the medical director of the Allaince and really kind of devote a lot of your time to this?
So I come from a family of psychiatrists. So my parents are both psychiatrists. My grandfather was, my uncle, and something like number, I don't know, 10 on the Ritvo side. And so I knew I was interested in psychiatry when I was in medical school. And then I increasingly knew I was interested in addiction. I think in part because I liked the heavy focus on kind of the neurophysiology of withdrawal management, as well as, this was a group of patients that often are greatly dismissed or not believed. And yet if you hang in there with them and you really come to understand the disease of addiction, you can see these patients get markedly better and really turn their lives around. So I found it really rewarding. And then as I was going through training, also seeing, that I guess my residency was really, started in 2012 at the beginning of the opioid epidemic, and saw people, increasingly kind of struggling with how do we treat pain when they're, now these opioids are seen as dangerous and highly addictive. And then similarly started to see that applied to benzodiazepines. But I think we're so quick to make something all or nothing or black and white. It's either good or it's bad. If someone's on a benzodiazepine, they need to be off of it. And then would see people really struggle because they'd be tapered too quickly. It would be seen as this like power struggle with the patient, or clearly if they were reluctant to go down on their dose or come off, this must be a sign that it's addiction, rather than, I don't know. I think then with time working with more of these patients, realizing like these patients are really suffering. They were given this medication as something they were told would help, and probably initially did. And now they're being told they're not supposed to be on this medication. Many of them weren't told or don't remember because of the distress they were in, and it wasn't clearly conveyed that there was risks with staying on these long term, and the physical dependence and rebound symptoms and all these things. And now feel like we're telling them they're doing something bad and wrong, and it's very confusing. And while they may identify that they're having side effects or things they don't like from these medications, they also are worried that living without them may feel even worse. And so they feel like they're in this horrible place, and suddenly the people that are supposed to be helping them either don't believe them, or if they feel like they're being labeled as either a difficult patient or something like that. And so I saw this real opportunity that similar to addiction, where we could truly partner with these patients and take an approach of, let's see what we can do that will be better. And that might be getting you down on the dose. That might be with time getting you completely off. And I found it's really hard to predict which patients are going to tolerate what. Some are able to taper pretty quickly, come off completely. Some taper down just till the very end, and then really don't do well getting off the last little bit for probably a variety of both physiologic and psychological reasons. And just needing to like partner with the patients and really try to continuously assess those kind of risks and benefits. And at the same time, helping revise how we have the initial conversation if we consider starting these medications. And so trying to do that. So as I went from addiction psychiatry fellowship training to becoming on faculty with the University of Colorado. And a lot of my work is actually in kind of general outpatient psychiatry. So a lot of it, while there's also a fair amount of co-occurring substance use disorders, there's a lot of patients just being treated for anxiety or insomnia that have ended up on benzodiazepines chronically. And so I found a real opportunity to work with the residents who are treating these patients and try to maybe alter their approach to working with these patients so that it's both more pleasant and more beneficial for everyone.
Great. I think this is probably a good time for me to ask you, because I mean you've recently done the guidance on I guess the benzodiazepine prescribing, and you're also involved in teaching, I guess, the next generation of physicians at the University of Colorado about these medications. So from your perspective, what do you wish people knew about these medications when they I guess when they started their patients on them? I guess, what do you wish prescribers knew, so the physicians?
Yeah. I mean, I think I wish more physicians knew and had seen and believed about bind, and that some individuals have have whatever this predisposing, probably multifactorial predisposition to bind, and really suffer and really struggle as a result. And we don't yet know how to predict who it's going to be. And so always keeping that in mind when starting these meds that, that could have that, and making sure patients really do get, and that's probably, not just having them sign something, or not just assuming they know what these meds are, but that they truly understand, how this medication, once taken regularly for really a week or more, you're going to develop physical dependence, and what that means. I mean, I just saw a patient today who, as they're getting older, their primary care doc said, we should probably have you stop this medication because it will start affecting your memory, and didn't very clearly say, but we can't or shouldn't stop it suddenly. And the individual, trying to be a good patient and also being, not wanting to have cognitive impairment as they got older, stopped it cold turkey and had a withdrawal seizure. So clearly there's not adequate education going on with our patients a lot of times, that's either assume they understand these risks, or that really they're not that risky just because we do prescribe. They have been prescribed frequently. So I think that's
okay. So I think definitely the risk of bind should be, I guess, at the top of the list. I guess another thing which is interesting with these medications is that folks develop dependence to the anxiolytic or the hypnotic effect pretty quickly. That the efficacy of the medication really can wear off within, I guess, maybe 3-4 months or something like that in some individuals, and then you end up taking something and it's not really doing much for you. In fact, maybe it's making your anxiety worse. And I know there's some lines of research out there where they've looked at things like alprazolam taken long term, and it actually over time does not seem to maintain its efficacy response, which is terrible. If you have someone on a medication for several years, but it's really not doing so much for them, and you're essentially exposing them to this long-term risk. And a lot of the time, I feel like, at least in a lot of places these days, appointment visits are pretty short. If you're going to a family practice doctor and maybe you spend 3/4 of the time talking about your cardiovascular disease, they may not have time to kind of say, well, let's have a look at this benzodiazepine that you've been on. Let me understand why you were on it. Maybe it was just this brief thing that happened in the past that was related to contextual stresses, but now it's just kind of been continued for years. I feel like those conversations, they're less likely to happen, when I guess medicine is kind of being practiced in these really kind of short snippets where people are expected to do, a million things at once, to manage patients. Yeah.
Yeah, I'd love to see on my I don't know if it's a short list, but long list of interventions I'd like to try in the setting I'm in is something like I know a group in Canada did where they sent out kind of a brochure with education about the risks, long-term risks of benzodiazepines to any patient that was on a long-term benzodiazepine. I think it was maybe through the pharmacy. And many of them then became interested in trying to taper. This is the Tannenbaum, the name's now escaping me, the name of the trial, but I want to say like Encompass or something. But the biggest problem is they did a pretty quick taper, and I imagine there's some people that did not tolerate it. But just the idea of, if you approach people non-judgmentally about, educating them about these things. I mean, most people aren't going to say, oh, as I get older, I would like to be on something that might make my memory worse, my attention worse, and put me at an increased risk for falls, or when I, between doses, I'm going to feel more anxious and potentially get shaky. So if you can find them in a moment where they're able to have the time and space to think about that, then maybe we can get their buy-in to try to slowly taper it.
Oh yeah, and to boot, and if you're on this, you may develop some kind of permanent neurological problems that are absolutely debilitating. And there's no way we could predict who that happens to, which is the most frightening thing about it. Shifting topics now. I mean, we talked a little bit about deprescribing, but you've written a deprescribing guidance as well. So I'd like to ask you, what do you wish that physicians and prescribers knew about tapering patients of benzodiazepines?
Yeah, I mean, and I will in no way take full credit for it. Stephen Wright did a lot of the heavy lifting along with a lot of the members of the work group that worked on it. But I'm glad to be able to say I was part of it. I think first and foremost, there's no one size fits all. I think it's especially with so many potential factors and symptoms that individuals can experience. You really have to figure out for each patient what's going to work with approaching it, and realize, I mean, like you were saying, with the symptoms themselves coming and going, that how you need to approach the taper may change over time. And so I think, I tell the residents, you want to start as low of a reduction initially as you can, because you want to get the patient's buy-in. You want them to feel like they can handle this. If you do too big of a cut initially and they feel really destabilized, significant distress or dysfunction, they're not going to want to proceed anymore. They're not going to have the confidence that they're going to be able to do this. So I think knowing that, I think, thinking of things from, what formulations do these meds come in, making sure patients understand, we don't have great evidence yet of, do you stay on the same med and try to taper it? Do you cross taper to long acting? I have several patients that are doing microdose tapers, and that seems to work very well for them. I've had other patients that, while I think they might have benefited from doing that from a medication dose standpoint, they don't have the kind of health literacy level or the support to be able to do something like pipette and measure and do all these things. So we're have to deal with the limitations of, the resources that they have. And so you're kind of having to balance all those things, trying to make sure, what other supports are you going to put in place? I think while you try not to go back up as you're tapering, I think also realizing, and I say to my residents, I'm like, this is a marathon, not a sprint. So, if we have to stop or pause at a given dose, we've still gotten them on effectively less medication, then that's still great. Like, I think people can get frustrated if we only talk about getting them off, and then they're not able to recognize their achievements of getting down on the dose and reducing that risk as it is. So I think those are some of the things that the deprescribing guidance tries to convey, as well as just, really looking at how else can we effectively and more safely treat the symptoms that we're initially treating. Ideally, everyone would have the time and ability to connect with, therapy resources, but unfortunately that's not a reality in a lot of places. But figuring out, other supports, actually we're working on a peer support curriculum on the consortium side. So that should offer additional kind of more evidence-based support to individuals. And trying to think what else is in the deprescribing guidance. I think, we don't have a lot of evidence of what else can help these patients symptomatically from a medication standpoint. I think often less is more. Many of these folks are kind of hypersensitive. Their system has become very sensitive to medications. So it is really kind of unique to each patient of if and when they want to try something else to see if it helps symptoms, but we don't have good evidence. And I certainly have spoken with plenty of patients where they felt like adding anything made them just feel worse. So I think those are all things important for prescribers to keep in mind.
Yeah. And, when you're talking about, when you were describing, I guess, the guidance and your experience treating patient, I was also thinking about how important it is to have that term bind, because it really is two separate things. I mean, so at least the way I see it, and I treat these patients a lot in clinical practice, it's you can have someone with no neurological injuries. They don't have that. And, they became aware that they wanted to come off this medication. And that's fairly straightforward. We kind of think, 5 to 10% cuts, we go slower if they need to. And, we wait, 2 to 3 weeks between dose reductions. We see how they're doing. And it's pretty quick. This is something that could take place over 3 to 6 months, and they're off and there's no complications. The other beast is treating bind, which, I mean, it's not just people kind of having anxiety. I mean, we've got folks in our practice who are debilitated by neurological symptoms. They have electric shock sensations kind of coursing through their body. They have no appetite. They feel really depressed, really anxious as well. They have paresthesias, and kind of managing that. It's, we're not talking about managing, I guess, withdrawal anymore. We're talking about managing an insult to the nervous system where pain is a problem, where eating is a problem. And then, as you said, this is, I won't say it's rare. There's more and more people having this, but it's not everyone. So it's not like we'll ever have clinical trial research on these things. So there's a couple doctors out there, yourself, myself, other people in the community, and we're kind of flying by the seat of our pants trying to help these people, just take it one day at a time, because at least my experience shows the majority of people do recover. If you can just keep them comfortable enough, as time goes on, these neurological symptoms tend to improve. So and I think bind really speaks to that. We're not talking about a withdrawal problem. We're talking about this kind of neurological devastation that happens with some people. Yeah.
Extremely well put. And we need, I hope someday we can get some more research, but I think this is where I see, long COVID has the benefit of affecting so many people at the same, like in such a short period of time, that really drives, the ability to do research and fund research. So, but hopefully, I mean, there's a few documentaries that have come out in the past year that I think draw some attention to it. And so hopefully if there's some kind of increased public awareness and, maybe someone that becomes particularly interested in it because of a affected loved one that has, some further ability to help us move the dial and get more information, that'd be wonderful.
Yeah, no, and the movies are great. And I'm glad you kind of talked about awareness, because I think a frustration that a lot of people may have, if they've been injured by this, it's like, what are people doing about it? Because at least from my perspective, and maybe you share this, I'm not sure, but there seems to be a gap. So, we have drugs that get approved through the FDA. They come out with with labeling, and there's warnings in there and such, but it's not really affecting clinical practice, because what we're seeing on the ground is a lot of people left on these medications, not really informed about things, and then I guess we treat the harms. And so I'd like to ask. So I know the Allaince, and also I guess your work with the Colorado Consortium. I mean, it's like a multi-pronged approach to getting the word out about these things. And I mean, you mentioned movies, although I don't think you're affiliated with them, but you may know the people there.
Right.
But there's also things like, I know you guys have done symposiums. You're creating these guidances. I mean, right now we're doing some social media things, but I was hoping, just from your perspective, you could tell the audience out there, what are the things these groups are doing right now to try and get the word out there to prescribers and patients, so more people don't run into these same kind of problems.
Yeah, I think and thinking both at a local to regional to national level, and then also on a doing education at the various levels of medical education, not because any one presentation will greatly impact prescribers, but at least it may plant a little seed that they'll think about it when they see a patient and the patient complains of having some unexplained symptoms, and they see they've been on benzodiazepine for a long time, or have been recently started, I guess is also potential. So on the education side, trying to make sure that whether it's in undergraduate or medical school, graduate, residency, and then postgraduate or continuing medical education, that we're going to different conferences and presenting and getting the word out about this. I think that's first place. In Colorado, we've been able to push through some or support some legislation to help decrease, hopefully, the initiation of benzodiazepines. So modeling off of what has been successful with opioids, we're able to get a bill passed that limits the initial prescription of a benzodiazepine to 30 days or less if someone hasn't been prescribed in the last 12 months. And the hope is that, someone's not just given a prescription with a multitude of refills and sent on their way, but that it's encouraging providers to revisit the conversation of what else they can do to help these symptoms that doesn't carry the same long-term risk. That just went into place about a year ago, so I don't yet know, that they've been able to look at the impact. But hopefully other states might take a similar approach of trying to look at how to put some policy in place that could limit prescribing. Same in that legislation, they also added safe prescribing and tapering of benzodiazepines to a list of potential topics that providers are required to learn about and get a certain number of hours prior to renewing their license. And so I think, that's all helping kind of get the word out there, and hopefully eventually influence practice. Then of course there's the kind of larger federal level. So with the FDA, the Allaince, before I joined, it was really instrumental in helping get the black box warning, the newest one, the updated one that really describes both the physical dependence and really bind, as well as, has tried to find various angles, whether it's potential educational trials or working with different organizations to get literature, evidence reviews, to try to see just how all the places we can potentially try to influence the overall both patterns of prescribing as well as knowledge and understanding of bind. And so, it's hard to see exactly where the impact lies, but hopefully kind of just taking all these different approaches, a few things stick and move the needle a little bit.
Yeah, no, I love that. And, just hearing you talk about that, and I guess spending some time on your website and on, I guess, the Allaince's website and seeing everything that's been done. I mean, I cannot overstate how big of a deal it was to change the boxed warning, because bind/protracted withdrawal. I think that was the first time that a major health authority, and this is, government health authority like FDA, even including groups like the American Psychiatric Association or maybe addiction groups, really kind of came behind that diagnosis and just said, this is real, and they list protracted withdrawal and they're under that name, and and they list out the symptoms. And interestingly enough, I was a medical expert for a case not so long ago, and we had a favorable decision, that was settled, where someone who had protracted withdrawal, where they were injured, essentially someone started them on a medication, and it kept on getting refilled, even though it was temazepam, and the guidelines, in the label it says 14 days only, and then the provider had just kind of kept on refilling it. And eventually they developed protracted withdrawal/bind when they were abruptly withdrawn from it. And we got a favorable settlement. And things like that could never have happened
if it
unless
wasn't
there was in the label. Yeah. And
I would love to do a brief survey of prescribers to see how many people are actually aware of the updated label. I think it might be underwhelming. But it's there, and that that just certainly holds credibility and points to it. That it really is something prescribers need to know.
Yeah. And this legislation in Colorado is great because, once that's the state law, I mean, hospital systems, they will need to put quality systems in place to make sure that their physicians are reviewing it. And I hate to say this, but some of that annoying stuff is really what influences patient care. When you have someone looking over your shoulder and just saying, hey, this is not going, with the state law at the moment, think about something else. And then, I mean, another thing out there as well is, it can be fear. If you're not aware of these things, now that they're labeled, in warnings and precaution, where they put the most important side effects of the drug, where essentially anyone prescribing them should know and should inform patients about. I mean, that's where these things are now. So, I mean, you could end up in a lawsuit as well. And I hate to say that motivates people, but we both know it certainly does.
Yeah. I think, and I think what can be hard is for people to understand that, like you described with the case you're the expert on, that it goes both ways. While we need to try to not, start fewer people when we start them, have them be on lowest dose for as shortest time as possible. For the people that have been on these a really long time, we need to, approach it very cautiously and carefully, because if we decrease them too quickly or they stop abruptly, that's now, can be very disruptive, dangerous, and disabling. So
that's a good point.
Yeah. Just because this warning comes out, all the more reason to be more, more cautious.
And I don't know if you saw this in your practice, but when this happened, we got a lot of people who came to us saying, my physician wants to take me off in 2 weeks. He won't hear it any other way. And so they came to our practice to do a more gradual taper. And that's exactly the problem that you're talking about. There are these gaps there, okay, the risks are in there and it's getting communicated to people, but this information that, you're generating through your work about how to safely get people off, I mean, that still needs to get out there to make sure that people aren't hurt. Because I'm sure inadvertently, when this warning came out, some people were tapered too rapidly, and now they've got these problems. So I mean, there's a lot of work to be done here.
Well, and we need to learn from what we saw with the opioid epidemic, right? I mean, there's a lot of people that did get harmed because they were forced to taper off their opioids.
They become suicidal, right? That's
there's
that
research
happens
out there that you do have to consider is some of these individuals will do better staying on some of the medication. This is iatrogenic, and while we should decrease who we start on it, you can't just take people off quickly. So it's challenging work, but also extremely rewarding as you work with these individuals, and hopefully we can do them
Mm-hmm.
justice and get them both functioning better and feeling better,
Mm-hmm.
and improve how we utilize these medications, and kind of all, at least in our line of work, all psychiatric medications. So.
Sure. I think around about now might be a good time to wrap. But I guess I want to say, I mean, you may be aware of this, but in case you're not, I mean, your work and the stuff that the Allaince is doing and the consortium, it means so much for people, especially people who have been hurt. The fact that someone is working on educating physicians, the fact that people are working on how to help people with withdrawal problems. I think oftentimes people are going, why isn't anyone doing this about it, anything about this? And you guys are. So, I mean, it's a huge deal. So, thank you so much for, everything you've done for this space, I guess on behalf of the people with Bind. And thanks for
Yeah.
agreeing to do this interview.
And you can hear the chorus of young, hungry children behind us. But my pleasure. And I'm so glad that you're part of this group as well. And look forward to future discussions and collaborations.
Yes, same here. Yeah, have a nice evening. Go and take care of the hungry children.
Thank you. Bye.
Bye.